This figure summarizes the mechanism of post-transplant immunosuppressive agents, and understanding this layout is essential when we are forced to change therapy in the setting of drug-induced TMA. Start at the top of the diagram. Here you see the antigen-presenting cell interacting with the T cell through the MHC-T cell receptor complex with an additional co-stimulatory signal. On the left side, this co-stimulatory pathway is blocked by belatacept. Belatacept inhibitors CD80, CD86 signaling, preventing full T cell activation without exposing the endothelium to CNI-mediated toxicity. Now look just below that, still on the left side, here are the CNIs, tacrolimus and cyclosporin. These agents block interleukin-2 transcription by inhibiting the calcineurin pathway. But in susceptible patients, they disturb the endothelial hemostasis and can directly precipitate TMA. That's why when TMA is suspected, these drugs are usually the first to be reduced or withdrawn. Now shift your attention to the center. Interleukin-2 is the key signal driving T cell proliferation. Blocking this signal at different levels is how we maintain immunosuppression after stopping a CNI. Move your eyes to the upper right. Here you see interleukin-2 receptor blockade with bezriximab. This is often used during induction or as a temporary strategy while maintenance immunosuppression is being restructured. Just below that, on the right side, is the mTOR pathway. mTOR inhibitors, sirolimus and everolimus, block downstream proliferation, but they can also impair endothelial repair and in sometimes cases worse in TMA. So switching from CNI to mTOR inhibitors is not always a safe solution. Now look at the bottom center. Here are the anti-metabolites, mycophenolate, mofetil, and ethioprine. They suppress T cell proliferation without directly injuring the endothelium, making them relatively safer backbone in patients with TMA. Finally, at the bottom of the diagram, you will see T cell depleting therapies. This include ATG and CD52 blockade with alemtuzumab. These agents are typically used for induction or high immunological risk patients and may be incorporated selectively when maintenance options are limited. So when managing drug-induced TMA, the goal is not simply to stop a medication, but to rebuild immunosuppression in a way that protects the graft while removing endothelial stress. And this diagram explains exactly how we do that.